Hello everyone, welcome back. So we have covered the internal anatomy of different teeth in previous lecture. In today's discussion, we'll be covering the access cavity preparation of different teeth. So let's start. Basically, what is an access cavity preparation? See, access cavity preparation is the coronal opening. That means it is the preparation of coronal part. Why do we do that? To gain access to the root canal system. To gain access to the root canal system. Why do we need to gain access to the root canal system? For cleaning, shaping, and obturation. Simple. So, basically, access cavity preparation, it is the coronal opening or coronal preparation so as to gain access to the root canal system for the purpose of cleaning, shaping, and obturation. So let's see what are the objectives of access cavity preparation. See, for access cavity preparation, we need to have direct straight line access to the apical foramina. Now, why do we need that? If we have straight line access to the apical foramina, here our instrument will go unobstructed to the apical foramina without any deflection, and thus it will decrease the possibility of iatrogenic errors and it will result in the optimum shape of the canal. The another objective is that we should do the complete deroofing of the pulp chamber. Now, what is deroofing? For example, you can see in this image, this is incomplete access cavity preparation with dentine shoulder, which is obstructing the entry of the instrument into the canal. So if it's there, it will cause obstruction of the instrument while going into the canal. It will prevent the straight line access to the orifice. It will cause difficulty in locating the canal orifices. For example, if we remove this dentinal shelf, so our access cavity will be like this. So this is the final shape, and see the difference. We have straight line access to the apical foramina. We have improved visibility. The instrument is not getting deflected, and there is complete debridement of the pulp chamber. So we should do complete deroofing of the pulp chamber. But in lieu of straight line access or complete deroofing of the pulp chamber, we cannot just cut tooth structure. We should follow the minimal loss of structural integrity of the tooth so as to avoid weakening of the remaining tooth structure. Clear? The definition and objectives. Now, what all instruments are needed for access cavity preparation? See, questions from this topic can be asked in form of image-based question. They can show you one image and ask for the instrument, or it can be just multiple choice. Following instruments are needed for access cavity preparation, except then you have to mark the irrelevant instrument. Clear? So let's see what all instruments are needed for access cavity preparation. See, first is the Endodontic Explorer. This is DG16 Explorer. You can see this. This is DG16 Explorer. The design of DG16, it helps to identify the canal orifices and determine the canal angulation. This explorer is used for access cavity preparation. Then are the access opening bars. These access opening bars are diamond round bar. The number 2 and 4. These bars, they are used to gain entry into the tooth structure. The number 2 is smaller bar, which is used for anterior and premolars, whereas number 4 is used for molars. Similarly, tapered diamond bars, they are used to flare the access cavity preparation. Then is the transmetal bar. Transmetal bar is used for cutting off any type of metal. When you need to do the re-RCT or RCT with any metal crown, then to cut the metal, you need transmetal bar. It provides proper efficiency without any vibration. Also, this is specially indicated for entering a hot tooth, that is tooth with acute or symptomatic irreversible pulpitis where patient is already having pain. So to further prevent the aggravating of the pain, you need to use the bar which produces minimum vibration. So here these bars are indicated. Next is the endo bar. This is the endo bar. This is the safe ended Tapered carbide burr, it is used to flare, flatten, and refine the internal walls of the access cavity. It has non-cutting tip, and because of that, it can be safely placed into the pulp chamber. You can see in this image without any risk of perforation. Clear? Then extended shank round burrs or Muller burrs. The extended shank, the long shelf, helps to improve the visibility and to reach the deep pulp chamber. Then Gates Glidden drills and endodontic spoon excavator with long shank. All these instruments, they are used for access cavity preparation. Clear? Now before going for access cavity preparation, we need to follow some laws. These are the laws of access cavity preparation by Kranzer and Ranko. Please listen to these laws very carefully because many a times question come from these laws only. So let's start. First is law of centrality. Now what does it mean? It says that floor of the pulp chamber is almost located at the center of the tooth. This is very clear from this picture also. The second law is law of Cemento enamel junction. This says that distance from external tooth surface to the wall of the pulp chamber, this distance, or you can see in this image also this distance, it is same throughout the tooth circumference at CEJ. It is almost same as that of law of centrality, that pulp chamber, it is located in center of the tooth at level of CEJ. Clear? Then law of concentricity. It says the walls of pulp chamber, they are always concentric to the external tooth surface at the level of CEJ. Basically, this means that anatomy of the external tooth surface, it reflects the anatomy of the pulp chamber. Similarly, you can see this is the anatomy of first premolar. Similar is the shape of external tooth surface. Similarly, you can see here this is the shape of pulp chamber. It is almost similar to the morphology of the external tooth surface. Clear? Then is law of color change. What does it mean? It means the color of the floor of chamber. It is darker than the cavity walls. This floor of the chamber is darker than the cavity walls. Fine. Then is law of symmetry. Except for maxillary first molar, the canal orifices are equidistant from line drawn mesiodistally throughout the pulp chamber. Suppose this is the mesial surface, this is the distal. So if we draw the line mesiodistally, orifices, they are equidistant from this line. In case of maxillary first molar, if we draw the line here mesiodistally, the chamber is located mainly on the mesial side. So this principle is not followed by maxillary first molar. Just remember this because it is question of choice in MCQs. You can also see in this image, if we draw the line mesiodistally, the canal orifices, they are equidistant from this line. Similarly, here you can see in mandibular first molar also, the orifices are equidistant from the line drawn in the mesiodistal direction through the floor of the pulp chamber. But in case of maxillary first molars, since the chamber is mostly located on the mesial side, this law of symmetry, it doesn't suit to the maxillary first molar. Now, what exactly law of orifice location mean? It means that orifices of the root canals, they are always located at the junction of wall and the floor. Suppose this is the access cavity, this is the axial wall, and this is the floor. So the orifices are located at the junction of walls and the floors. They are not located like here or here. Suppose this is the access cavity preparation. So these orifices, they are located at the angles in the floor and wall junction. Similarly, here you can see this is the wall and this is the floor, and orifices are located at the junction of floor and the wall. Clear? So till now we have covered the internal anatomy of different teeth, the variations in internal anatomy, laws of access cavity preparation. Now coming to the access cavity preparation of different teeth. First, we'll be covering the access cavity preparation of anterior teeth. Access cavity preparation of central and lateral incisors is triangular in shape. For example, this is the central incisor, this is incisal surface, this is cervical surface. So, the access cavity is triangular in shape with rounded margins where base of the triangle is towards the incisal surface and the apex is towards the cervical surface. Now the question is, how do we achieve the access cavity preparation of anterior teeth? See, initial point of burr entry is the middle of the middle third. This is, as you know, as we divide the crown into three halves, this is cervical, middle, and this is incisor. This is mesial, distal, and this is middle. So middle of the middle surface, this, where the cingulum ends basically. So initial point of entry is middle of the middle third of palatal surface, keeping the burr perpendicular to the long axis of the tooth. This is long axis of the tooth. So burr is at 90° to the long axis of the tooth. Fine. It is perpendicular to the long axis of the tooth. Once we gain entry, the burr is directed 45° to the long axis of the tooth, like this. Fine. This helps to penetrate into the pulp chamber. Once we feel the drop in, that means we gain entry into the pulp chamber. Now remove the roof of the chamber by moving round burr from inside to outside. So we gain entry into the chamber and remove the dentinal roof. After this, we remove the lingual shoulder using Gates Glidden drills and safe tip diamond or carbide burrs. So by this we gain straight line access into the apical foramina. Fine. So this is how we gain access to the root canal system of anterior teeth. The basic shape of access cavity is rounded triangle where base is towards the incisal surface. But as we move to lateral incisor or canine, this triangle tends to get oval in shape. Fine. So please check these points because many times questions come from this topic, that what is the initial point of entry of burr? So it is in the middle of the middle third of the palatal surface. What should be the angle of the burr in the first step of access cavity preparation? So it is perpendicular to the long axis of the tooth. And once we gain entry, it is 45° to the long axis of the tooth. How do we remove the lingual shoulder? By safe tip diamond or carbide burrs or Gates Glidden drills. What is the shape of access cavity? Rounded triangle where base is towards the incisal surface and apex is towards the cervical surface. How do we move the burr to remove the dentinal roof? Once we feel the drop in, we need to move the round burr from inside to outside. Fine. So many questions are asked from this topic. Similarly, we'll cover the access cavity preparation of other teeth also and the questions asked from that topic. Now let's see the access cavity preparation of maxillary premolars. As we have seen in internal anatomy, it has two canals. The buccal canal is located under the buccal cusp tip and the palatal canal is located under the palatal cusp tip. The pulp chamber, it is located in center of the occlusal surface, and if we check the shape, it is oval in shape. So how do we gain entry into the pulp chamber and the canals? First, penetrate the enamel using the round burr and move it buccolingual direction. It is moved in buccolingual direction. Which burr is used? Round burr, and it is used in buccolingual direction. Fine, like this. And once you feel the drop in, locate the canal orifices using Endodontic Explorer. And again, suppose this is the obstruction, this is the dentinal roof. We need to remove it by using the round burr from inside to outside direction. So this is how we remove the dentinal roof. Similarly, we removed the lingual shoulder in anterior teeth. In case of premolars, remove these bulges using the safe tip carbide or diamond burrs or Gates Glidden. And this is how we get the straight line access to the apical foramen. Clear? Kindly solve all the questions, and if you feel any doubt, let me know. So what is the final shape of excess cavity preparation of maxillary premolar? Suppose this is the maxillary occlusal surface, this is the buccal, lingual. So the buccal canal is under the buccal cusp tip, lingual is under the lingual cusp tip, and this is the oval shape axis cavity preparation, which is wider in the buccolingual direction. Clear? Now coming to the axis cavity preparation of maxillary molars. See, as we have already seen that maxillary molars, they have 3 or 4 canals, where if 3 canals are present, then it's mesiobuccal canal, distobuccal canal and palatal. And if it has 4 canals, then it's MB1, MB2, distobuccal and palatal. This we have already seen that in 70% cases, if we check by naked eye, we can identify MB1 and MB2. But if we check under magnification, it is in 96% cases that MB1 and MB2 canals are present. So to gain access to the maxillary first molar, first we need to determine what is the mesial and distal outline so as to avoid unnecessarily cutting of the tooth structure. See, the mesial outline of the pulp chamber is the line connecting the mesiobuccal and mesiopalatal cusp. So this is the mesiobuccal cusp, this is the mesiolingual cusp. The line joining these cusps is the mesial boundary line. And the distal boundary is the oblique ridge. This is the axis cavity preparation. This is the boundary, and the area of axis cavity preparation is limited to that area. Fine. So we can say that most of the axis cavity. So we can say that axis cavity preparation is present only on the mesial half of the occlusal surface in case of maxillary molars. So again with the round burr, we gain entry to the pulp chamber. But here, what number of round burr we use? It's 4-number round burr. 2 number is used for anterior and premolars. And once we get the drop in and explore the canals, we de-roof the chamber using the round burr from inside to outside direction. Fine. This is done to get the straight line access and to avoid any obstruction for the instrumentation. And the bulges are removed by safe tip burr, and this is how we get the straight line access to the apical foramina. I think it's simple for you now. So this is the final shape of access cavity preparation for maxillary first molar, which is rhomboidal or triangular in shape, where mesiobuccal canal is located under the mesiobuccal cusp, palatal canal is located under the palatal cusp, and the distobuccal is located. This is palatal to the mesiobuccal and distal to the palatal. And what about this MB2? Where is it located? So this MB2, this is MB1, this is distobuccal, and this is palatal. This MB2 is located 3 mm palatal and mesial to the MB1. So this is located, MB2 is located 3 mm palatal and slightly mesial to the mesiobuccal canal, MB1 canal. So this is how we get the shape of this. Now again, what are the questions which can be asked from this topic? What is the mesial outline? What is the distal outline? Where is most of the axis cavity located in maxillary first molar? Which burr is used to initiate the axis cavity preparation? How do we de-roof the pulp chamber? How do we remove the bulges? And how many canals are there? Location of each canal? Shape of the axis cavity? What is the variation when we move posteriorly? So many questions which are being asked from this topic. Now another question which is asked is, what is shamrock preparation? Now what is this? Lubike showed that in search of MB2, which is located 3 mm palatal to the MB1 and slightly mesial, this is the palatal canal, this is the distobuccal canal. In lieu of searching MB2, rather than extending the whole wall mesially, just extend the preparation like this to avoid the over preparation. So, by this, as access cavity preparation, it requires a rhomboidal shape. So, he recommended the extension of only that wall, which results in the clover leaf appearance. Clover leaf appearance, which is known as shamrock preparation. Clear? So rather than overcutting and extending the whole wall mesially, extend the preparation slightly on the mesial side so as to have rhomboidal shape of access cavity preparation. The another thing which we need to keep in mind is we shouldn't have mouse hole effect. What is this mouse hole effect? See, mouse hole effect is extension of the orifices to the axial wall. This is the axial wall of the cavity preparation. See, if you check it carefully, this orifice is located on the floor of the chamber. This is located on floor of the chamber. Similarly, MB2 is located on floor of the chamber. But can you see this one? This is partially located on the axial wall. So this orifice is located on floor, whereas this is extending half to the axial wall. Now, what can be the reason of this mouse hole? This is the this is caused by underextension of the access cavity. And what will be the consequences of this mouse hole effect? It may result in hindrance to the straight line axis, and that may result in procedural errors. Clear? This can be asked as image based question or as a cause for mouse hole effect. What are the consequences of mouse hole effect? I hope it's clear to you. You can clearly see in these images that this molar triangle that tends to get narrower as we move posteriorly from first molar to second and then third molar. Clear? Now, finally, coming to the access cavity preparation of mandibular molars. See, again, we need to check the outline of access cavity preparation. So, what is the mesial outline of access cavity preparation? The mesial outline is the line joining the mesiobuccal and mesiolingual cusp tip. This is mesiobuccal cusp tip. This is mesiolingual cusp tip. So, line joining the mesiobuccal and mesiolingual cusp tip. And what is the distal outline? It is the line joining the buccal and lingual grooves. So this is how we achieve the shape of access cavity preparation of mandibular molars. Now how do we achieve this? Again, similar to other molars, the entry to the pulp chamber is made with the number 4 round burr in the central fossa. And again, once we gain entry into the chamber, we explore the canals using the Endodontic Explorer. Then we de-roof the chamber using the round burr and moving it in direction inside to outside. And then again, we remove dentinal obstructions using the safe tip tapered burr or Gates Glidden. And this is how we achieve the straight line access to the apical foramina. The shape of the access cavity when three canals are present, that is mesiobuccal, mesiolingual, and distal, then it is almost triangular in shape. And when four canals, that is mesiobuccal, mesiolingual, distobuccal, and distolingual is present, then it is almost rhomboidal in shape. And this shape tends to get narrower, triangular triangle tends to get narrower in second and third molar because canal orifices they become closer, and in second molar we also see C-shaped canal anatomy, which we have already covered in variation in canal anatomy. Fine. Please check all the questions related to access cavity preparation of different teeth. I hope you'll be able to solve those questions. If you feel any doubt, feel free to message or call me. Take care and goodbye.